my travel here is being paid by a drug company. So I have to ask you, how many of you believe that insulin is a therapy for diabetes? Can you raise your hands? How many of you do believe insulin is a therapy for diabetes? Very few. What is the therapy for diabetes? There is no therapy? Okay. I'm happy that you think this way. How many of you think mechanical ventilation is a therapy for ARDS? Even fewer. Why do you practice medicine though? Make diagnosis? Good. A few centuries ago it was the rule, you know. But anyway, today we're talking about mechanical ventilation. And the subject of my topic is why should we measure the patient's effort during assisted mechanical ventilation, or for that matter, during spontaneous breathing. But being a course of mechanical ventilation, the question is, why should we measure effort during assisted ventilation? First of all, you just heard to titrate the ventilatory support, because we want to know how much the patient is working, to understand why weaning sometimes fails, to know the total transpulmonary pressure, because we know is one of the determinants of ventilation-induced lung injury, because total transpulmonary pressure depends for the given lung on the tidal volume. To minimize the risk of ventilator-induced lung injury and to prevent, I don't like this term, but it's a complex term, to prevent patient self-induced lung injury. This is on the paper on the American Journal of Respiratory and Critical Care Medicine in press. First name is Laurent Brochard. So, first of all, this paper came out many years ago at the time when people were comparing 6 milliliters tidal volume with 12 milliliters tidal volume. A few of those patients, quite a few of those patients, were not happy to be ventilated with 6 milliliters per kilo because they felt the tidal volume was too small. And being ventilated in volume assist, they developed, in a good percentage, acute pulmonary edema, many acute pulmonary hemorrhagic edema. And that, you know that because Laurent just explained it, because the airway pressure dropped during inspiration when they tried to get a higher flow from the ventilator. And we know that if we want to make negative airway pressure during inspiration, a very simple model is to increase airway resistance. If you want to make a model of hemorrhagic pulmonary edema, one of the ways is to increase inspiratory resistance. On the opposite side, we have learned that paralyzing patients in certain conditions, paralyzing severe ARDS patients, improves survival. And that really was a surprise. Now, we have learned that it's not enough to look at airway pressure, because transpulmonary pressure is actually the sum of airway pressure plus intrathoracic pressure. So in this case, we have 30 airway pressure, minus 10 within the chest. Now transpulmonary pressure is 40, and the tidal volume has actually increased because transpulmonary pressure is increased. And if I want to bring back the risk of ventilator-induced lung injury down to where it was, now I have to decrease airway pressure to 20, provided I know then that the intrathoracic pressure is minus 10. Minus 10 plus 20 makes 30, exactly like it was during controlled mechanical ventilation. So negative intrathoracic pressure is an essential component of spontaneous breathing or of assisted breathing, for that matter. But keep in mind that this negative pressure, the patient's effort adds up to the pressure generated by the ventilator on the airways. So negative intrathoracic pressure increases transpulmonary pressure. It has an effect on the heart function. Negative pressure in the chest, spontaneous breathing, favors pulmonary edema because it increases left ventricular afterload. And if airway resistance or flow are higher than normal, like in ARDS, patients in ARDS are tachypnoic, dyspnoic, they have a very high respiratory drive. In the initial phases of ARDS is described as tachypnoic and hypocapnic. The patient hyperventilates. If we have high inspiratory flow or high airway resistance, then alveolar pressure becomes negative, or at least lower than end expiratory pressure. If you have an airway resistance, we all have an airway resistance, but if we have an airway resistance here, when we have 20 of airway pressure, and we pull to get the air in, according to resistance, the alveolar pressure must be lower than airway pressure, otherwise air will not flow to the alveoli. By the way, keep in mind that in ARDS, airway resistance is increased. When the baby lung is 300 milliliters, then the airway resistance is 5 to 7 times higher than in a normal lung, because we are ventilating a very small portion of the lung. So the baby lung has a high airway resistance. Here you see airway resistance against end expiratory lung volume in patients with ARDS. The lower the FRC, the higher the airway resistance. Now, we have computed alveolar pressure during pressure support compared to controlled mechanical ventilation. And we can see that while alveolar pressure is easily computed during controlled mechanical ventilation, and we know it is positive, when we decrease pressure support, the alveolar pressure goes down, down, down to levels lower than PEEP in average. And the alveolar, as we increase inspiratory flow during pressure support, alveolar pressure goes down towards zero or sub-zero levels. This is the cartoon Laurent just showed you. And the main difference between spontaneous or assisted breathing and controlled breathing is that in controlled breathing, alveolar pressure is higher than PEEP throughout the respiratory cycle, both inspiration and expiration. At the opposite, spontaneous breathing makes alveolar pressure drops during inspiration. And then you say, yeah, but it gets positive during expiration. Exactly, as positive as it was during control. In total, the difference is that we have positive pressure during expiration, both during control and during spontaneous, but we have a negative alveolar pressure during spontaneous, while during control is always positive, even during inspiration. So I skip this one because you all know this, that if we have a patient under controlled mechanical ventilation and we want to wean him, one of the reasons of failure is heart insufficiency, because the negative intrathoracic pressure makes the left ventricular work increase because of an increased afterload, increased transmural pressure on the left ventricle. And this is a paper by François Lemaire many years ago, showing how wedge pressure increased when moving from controlled ventilation to spontaneous breathing. But we do not need an insufficient heart to get into pulmonary edema. We have probably a normal heart in ARDS, but we have a leaky lung. So the negative alveolar pressure, the negative intrathoracic pressure favors the accumulation of water in the interstitium of the lung. And that is called interstitial lung edema. Sometimes we make mistakes. We move this patient from controlled mechanical ventilation to spontaneous, and he got an increased pulmonary edema. And so, very quickly, what the cause of ARDS is probably the fact that the patient gets a leaky capillary system in his lung. Then he's in his bed, in the ward, and he struggles to breathe. He gets dyspnoic, he has a high respiratory drive, he makes huge negative intrathoracic pressure and negative alveolar pressures. So we start with some capillary leak, we get some interstitial edema, the gas exchange is not really impaired at this time, but the respiratory drive is high. The minute ventilation goes up, PCO2 goes down, the patient is dyspnoic, lung gets even more edematous, the capillary leaks more because of the negative pressure, and this is the vicious cycle that ends up with a white lung. And there is, to break this circle, either we stop the leak of the capillaries or we stop the inspiratory effort of the patient, which is mechanical ventilation. So mechanical ventilation might be useful to stop the evolution of lung injury. Positive pressure ventilation might be useful to stop the evolution of the initial insult. So how can we get aware of what's going on in our patient? We should be able to measure his effort, his inspiratory effort, and his inspiratory drive. The effort is made by the inspiratory muscles, And we can measure the pressure generated by the inspiratory muscles by using esophageal pressure. Here we plot airway pressure, flow, and esophageal pressure. This is the work done by the ventilator, raising the pressure above the atmosphere. And this is the work done by the patient, making the esophageal pressure drop below the relaxed pressure volume curve of the chest. In a paralyzed patient, the esophageal pressure will be here, the blue one, but the patient makes it go down here. This is the pressure generated by the patient. This is a patient successfully weaned. You see the esophageal pressure drop here. Sorry, this is a patient failing the weaning, a huge pressure drop in the esophageal tracing, while a success patient have a much smaller pressure drop for the same flow. This is a patient in CPAP working very much, and you see that the pressure drop on the esophageal is very big. Look here. Going to pressure support, approximately the same peak flow. The airway pressure goes up because the ventilator works, and the work of the ventilator is reflected by a decreased pressure drop in the esophageal tracing. Obviously, esophageal pressure is not always as simple as measuring airway pressure. It can be done. It's not very stable. Many people do not like to use it. The interpretation of the tracings is not simple. The absolute value of esophageal pressure is disputable. We can think it's not important, but we can estimate the inspiratory effort with alternative methods if we do not want to use the esophageal pressure. And so we have airway pressure methods. One of the ways to measure the inspiratory drive of a patient is very simple, is PO1, the drop in the airway pressure during the first 100 milliseconds of an occluded inspiration. If the ventilator occludes the airway at the start of inspiration, it takes some time for the patient to understand that the ventilator is not working, and he keeps pulling as if the ventilator was open. So we measure how much force the patient is willing to put into the next breath. And the good part is that every ventilator has a button or a program or some software, some trick to measure PO1. You just have, at my times, to push a small button and the ventilator will display a PO1 value. PO1 value change from one breath to the other, but we know that PO1s as low as 1.5, 2 centimeters of water is a good value. 10 is a minus 10 is the inspiratory effort of a runner at the end of the run. PO1 has a very good relationship with the work of breathing. Please do measure PO1. It's very simple. Tells you, makes you able to estimate the patient work of breathing without getting mad in making strange measurements. If PO1 goes up very much while you decrease pressure support, it's too early to wean the patient. If PO1 stays low, between 1 to 2.5 centimeters of water, you most probably will be successful in weaning your patient because the respiratory drive does not get crazy when you decrease support. PO1 is a measure of how happy is your patient during supported ventilation. He can be happy either because he's very good in breathing or because you have been sedating him. You know why he is happy. This is PMI. This is PMI, another very simple maneuver. You have to stop, you have to close the airways at the end of inspiration. Not every ventilator allows you to make an inspiratory pause during pressure support. But the point is that during inspiration in pressure support, the gray region is the pressure generated by the ventilator, and in this simple cartoon, the orange region is the pressure generated by the patient, the negative pressure generated by the patient. When we occlude the airways, the patient relaxes at a certain point, and the total transpulmonary pressure is displayed as a plateau pressure. It does not work on every patient, because some patients get mad very soon, but normally you have 300-400 milliseconds to make this measurement. The pressure right after the interruption tells you how much the patient is working at the end of inspiration. It tells you the total transpulmonary pressure at that volume. And this one is very easy too. If you have a ventilator that does it, you push the end inspiratory button and you know transpulmonary pressure. Low PMI means low effort. High PMI means high effort. This is high pressure support, low PMI. This is very low pressure support, almost CPAP, very high PMI. An alternative is to measure the diaphragm electrical activity. You know that we can measure the electrical activity of the diaphragm. Mackey exploited it, inventing the neurally assisted, adjusted ventilator assistance, guiding the assistance by the electromyography. But electromyography, the electromyographic signal is high when the effort is high, and is smaller when this effort is smaller. Like here, this is diaphragm electrical activity at different levels of diaphragmatic effort. So we have a good relationship between the electrical activity of the diaphragm on one side and the force generated by the diaphragm on the other side. Very good relationship, almost perfectly straight. Unfortunately, it changes from patient to patient and from time to time. Are we desperate because of that? No, we are not desperate, because we can calibrate the signal. If we have an inspiratory occluded breath, the patient will make a drop in his airway pressure, which is exactly the same as the drop in the intrathoracic pressure, because there is no change in volume. So we can calibrate the electrical signal with the pressure drop during an occluded inspiration, and we will know exactly how many centimeters of water of pressure are generated for each microvolt on the electromyography. All we need is an electromyographic signal, which is sometimes more convenient than an esophageal balloon, and technology is evolving. Let's see what comes out. So in conclusion, monitoring the inspiratory effort is essential, at least in some patients, to guide assisted breathing and to help preventing ventilator-induced lung injury during assisted ventilation. I think we should change the wording ventilator-induced lung injury into ventilation-induced lung injury, because spontaneous breathing can generate ventilation-induced lung injury, as I have shown you. Last message I want to give you is that spontaneous breathing is certainly more physiological than controlled ventilation. Spontaneous breathing might be more comfortable than controlled ventilation for the patient, but can be even safer in many occasions. But in some other occasions, where the respiratory drive is high, where the patient is very dyspnoic, when the patient has severe ARDS, mechanical ventilation, controlled mechanical ventilation and positive airway pressure might, if it is not a real therapy, it might really limit the evolution of pulmonary edema and possibly the evolution of ARDS. Thank you very much.